This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the journal In Vivo, published in 2026, titled Clinical and Biochemical Predictors of 30-Day Mortality After Decompressive Craniectomy, a retrospective cohort study.
This is a topic that hits home for anyone who spends time in the neuro ICU or the trauma bay. We all know decompressive craniectomy, or DC, is a life-saving intervention. We use it for severe TBI, malignant cerebral infarction, and ICH to manage refractory intracranial hypertension. But the reality is that even after we take the bone off and open the dura, early postoperative mortality remains high.
Exactly, Dr. Aris. The researchers from Pamukkale University in Turkey wanted to see if we could move beyond just clinical and radiological markers, like GCS and midline shift, and look at routinely available biochemical markers to better predict who survives those first 30 days.
Right. It's about risk stratification. We're often operating on patients with a rapidly declining neurological status, what this paper defines as a decrease in GCS of 2 points or more, or radiological evidence like a cerebral shift greater than 5 millimeters or basal cistern effacement. But what else is going on systemically? Alara, walk us through the study population.
They looked at a retrospective cohort of 102 adult patients between 2019 and 2024. These weren't just trauma cases. They included malignant cerebral infarction, intracerebral hemorrhage, and general refractory ICP. They collected data at 4 standardized time points: preoperative, early postoperative, 24 hours post-op, and at discharge or death.
And the primary outcome was 30-day mortality. Before we get into the predictors, what was the actual mortality rate in this cohort?
It was quite high, 70.6%.
That's a sobering number, though not entirely surprising given the severity of these cases. It underscores the last resort nature of the procedure in many of these clinical scenarios. Now, let's dive into the results. What were the clinical factors that stood out?
The big one was the preoperative Glasgow Coma Scale. Specifically, having a preoperative GCS between 8 and 13 was independently associated with improved short-term survival. The odds ratio was 0.16, with a p-value of 0.036.
That makes sense. If you're intervening while the patient is still in that moderate GCS range rather than waiting until they're at a 3 or 4, the brain likely has more physiological reserve. But the real meat of this paper is the biochemical analysis. They looked at sodium, potassium, hematocrit, CRP, and coagulation profiles. What did the multivariable logistic regression show?
This is where it gets very interesting for the residents and attendings listening. The study identified 2 strong independent biochemical predictors of 30-day mortality. First was the preoperative international normalized ratio, or INR, specifically a preoperative INR greater than 1.20.
An INR of 1.20? That's barely outside the normal range in many labs. What was the effect size there?
It was massive. The odds ratio was 25.60. If the patient's INR was above 1.20 before they hit the OR, their risk of 30-day mortality was over 25 times higher.
That's a powerful statistic. It really highlights the impact of coagulopathy, even subclinical or mild coagulopathy, on the outcome of a DC. It's not just about the technical success of the craniectomy, it's about the systemic state of the patient. Was there a second biochemical marker?
Yes, the neutrophil to lymphocyte ratio, or NLR, at the time of discharge, or in the case of the mortality group, the final recorded lab. They found that a discharge NLR greater than 3.13 was a strong predictor of mortality, with an odds ratio of 5.19.
So we have the INR representing the coagulation side and the NLR representing the neuroinflammatory response. For the residents listening, let's talk about why NLR matters. It's a marker of systemic inflammation. A high ratio usually means high neutrophils, often a sign of acute stress or infection, and low lymphocytes, which can indicate a suppressed immune state or severe physiological stress.
Exactly. And the researchers noted that while previous studies focused on pupillary response or lesion type, adding these biochemical variables significantly improved the predictive accuracy of their model.
Tell us about the model's performance. I saw they used the area under the receiver operating curve, or AUC.
Right. When they just looked at clinical factors, the pseudo R-squared was only 0.115. But after they added the biochemical variables, specifically that preoperative INR and the NLR, the pseudo R-squared jumped to 0.252, and the AUC reached 0.826.
An AUC of 0.826 is excellent. It shows good discrimination and calibration. And for the statisticians out there, the Hosmer-Lemeshow p-value was 0.765, which confirms the model fits the data well. It basically means that if you ignore the blood work, you're missing a huge piece of the prognostic puzzle.
One thing I found interesting in the paper was the discharge NLR. It suggests that the persistent inflammatory state throughout the hospital stay is just as telling as the initial insult. If that NLR stays above 3.13, the prognosis for that 30-day window is quite guarded.
It's a reminder that neurosurgery doesn't end when the last skin staple goes in. The management of the systemic inflammatory response in the ICU is critical. Now, Alara, did the study mention any specific subgroups like TBI versus stroke?
They included a mix: TBI, malignant infarction, and ICH. While they didn't find that the diagnosis itself was an independent predictor in the multivariable model, the preoperative GCS and the biochemical markers held true across the cohort. This suggests these predictors are universal to the pathology of the swollen brain, regardless of how it got there.
Let's summarize the take-home points for our colleagues. If you're looking at a patient headed for a DC, check that INR. If it's over 1.20, you're dealing with a much higher risk profile. And postoperatively, keep a close eye on the NLR.
And don't forget the preoperative GCS. The study reinforces that intervening while the GCS is between 8 and 13, before they bottom out, is a key indicator of improved survival.
It really comes down to this. These are routinely available markers. We don't need expensive specialized assays. We just need to look at the CBC and the coag panel with a more critical eye. It helps us inform families with more accurate prognostic information and helps us allocate resources in the ICU.
The authors conclude that integrating these conventional neurological predictors with routine laboratory biomarkers enhances our prognostic assessment. It's about moving toward a more holistic view of the neurosurgical patient.
Well said. This study from Pamukkale University is a great reminder of the systemic and neurosurgery. We are not just operating on a skull. We are operating on a patient with a complex biochemical environment.
That's all for today's episode. We hope this helps you in your next clinical round or late-night trauma call.
Thanks for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you next time.